Everyone, welcome and thank you for joining us for the Store It Safe Quality Improvement Project and for joining us for the learning session today. Today you're going to get to meet Dr. Sarah Denny, who I've mentioned to you as our medical director, and then many of us have already chatted, but I will be going through a few more pieces of information about the project at the end. Just to let you know, today's presenters have no financial relationships to disclose. We want to give a big thank you to Ohio Emergency Medical Services for funding our project. And then I just wanted to mention the practices that we have joining us for the project. So you can see them listed here. If you don't see your name, please let me know that, but I think that I captured everyone. To collect attendance, what we do is just have you put your name and your practice in the chat. So if you want to just chat in your name and what practice you're with, that would be very helpful. And then today, just to let you know, we're going to go through a bit of an overview and some background. Dr. Denny is going to focus in on screening and our resources. And then I'm going to do a quick project overview, some of which we already went over in our brief sort of introduction calls, and talk a bit more about workflows and then just a little bit of like homework to dos, things to be on the lookout for. So with that, I will turn it over to Dr. Denny.
Great. Thank you guys so much. One, for being here on this learning session, but also just for your interest in this project. This is definitely an area that I feel really passionate about, just, for many reasons. One, being a pediatrician and seeing these kids in my office every day, but also being a mom of teenagers, and just being a member of our society and seeing this stuff on the news day in and day out. So I'm kind of want to start with the why of Store It Safe. I'm sure that, as you know, these titles that you're seeing pop up on the news media and on the screen. Go ahead, Kristen, you can kind of just click through these quick little images here. Oh, okay. Yeah, so suicide, accidental shootings, the racial disparities that come with those are all really omnipresent, regardless of where in the state that you're practicing. Next slide. Okay, so if you have not seen this slide before, I use this one a lot because this is, if you're not already on board with having these discussions, this should be the big wake up call. For years and years and years, motor vehicle collisions and child passenger safety were the leading cause of death in kids. Well, we just saw for the first time ever that firearms become the leading cause of death in kids. So we have to be part of these conversations. We have to be part of discussions around safety with our families. We need to be part of discussions with safety in our schools, like all of this. The data is right in our face that this is a big problem and we need to be a part of the solution. Next slide. Okay, so I'm sure that this doesn't come as a surprise to anyone, but the United States accounts for the majority of children killed by guns when we're comparing to all of the high-income countries. Next slide. Okay, so a lot of the area of interest for me, starting actually when I was a resident, based on who was my mentor in residency, has been around injury prevention. And as every injury mechanism shows, there is racial disparities in the United States, and gun deaths are no different than these other injury mechanisms where we're definitely seeing racial disparities. We know that Black kids are about 5 times as likely as white kids to die from gunfire. Go ahead and you can advance to the next slide. Okay, so I just added this slide in yesterday because I just read this article over the weekend. This was looking at preteens. So we talk a lot about our teenagers and, the increased mental health crisis that we're seeing, the lack of access to resources, all of that kind of stuff. And this study was super eye-opening to me, where we're seeing in the younger kids, the preteens from 8 to 12, a significant increase. So they saw an 8% increase in suicide rates from 2001 to 2022. The greatest of these increases was actually in girls, and the Hispanic population saw the greatest increase as well. So when we talk about suicide screening a little bit later in this presentation, we talk about recommended ages, but definitely keep it on your radar for kind of the preteen ages as well, because the data is really clear that it's an issue for them as well. Next slide. Okay, I don't think that any of this is new news to you. Suicide is the second leading cause of death in kids 10 to 25. So these are our people. These are who we're seeing in our office. These rates continue to rise and continue to rise. For those of you who have done any sort of emergency room work or urgent care, the number of ED visits for people who are coming in with in acute crisis, suicide attempts, those numbers just continue to rise as well. Next slide. Okay, so we know that when we look at the data that kids who live in a home with firearms are at 3 times, some data even say 4 times at risk of dying by firearm by suicide. We know when we look at youth who have completed suicide by firearm, that 82% of those youth used a gun from within their own home. So that's why these discussions with the whole family are so critically important. Next slide. So there was a study done a few years ago where the investigators had interviews with people who had near lethal suicide attempts. And what they were asking was, from the time you decided to just commit suicide to when you actually took action, how much time had elapsed? And what they found was that 25% of those interviewed made an attempt within 5 minutes of making their decision to take their own life. Half of them took action within 20 minutes of their decision, and 71% took action within an hour. And the reason why I share this data with you is that if we can create a barrier between the person and the lethal means that can buy us an hour's worth of time to get them some help, we can save a life. So, having a crisis plan is great, having a counselor, having some resources, that's all good. But having a physical barrier between that youth who's in crisis and the lethal means to take their own life is really, really important. And that's where these gun boxes come into play. Not just, and I shouldn't say gun boxes, they're lock boxes. They're not just for guns, they're for any other lethal means, medications, anything that is unsafe that could put that child at risk. Next slide. So just reinforcing that barriers to lethal means are really effective in reducing suicides. It's very similar to a swimming pool. The most evidence-based intervention to prevent drowning is that barrier, that four-sided fencing that prevents the child from accessing the swimming pool. We need a barrier to prevent these youth in crisis from accessing their firearms. Okay, next slide. Okay, so the American Academy of Pediatrics put out this suicide blueprint for youth suicide prevention about, I don't know, maybe it might be 2 years now. It's a really great document if you have interest in this area. I'm not going to go through the whole thing. I just pulled out a couple key things. One is just like to reinforce why we're here. We are well positioned to identify and support youth at risk of suicide in any type of clinical setting. As with many things that we screen for, universal screening is key to catching those who are at risk. So universal screening is really key, and that's part of what we're helping you implement into your practice. How can we universally screen these kiddos? The other thing is having standardized clinical pathways. The standardized clinical pathway in my clinic might look different than what is in your clinic because I have different resources than what you have. So you guys will have to come up with the standardized clinical pathway that works for you. We'll give you some resources and some examples to hopefully help you along that process, but having a standardized clinical pathway is really helpful. And then the other thing, so many times we hear well, I just don't have time. It doesn't have to be you. So leveraging the strengths of all the members of your care team, leveraging the strengths of a social worker, if you have an integrated psychologist or you have some other mental health specialist in your clinic, it's a team thing. leveraging your registration staff to help, that's what we do in our clinic is the registration staff like gives the screeners out. So it's not on me. So, you know, just leveraging the strengths of everyone to help kind of get this work done. Next slide. Okay, so this information comes from that same suicide blueprint that I mentioned earlier. We know when we look at healthcare system contacts of people who have taken their own life, that 80% of adolescents had visited a healthcare provider within the year of their suicide. 50% had visited an ER within the year before their suicide. 40% had had some sort of contact with their healthcare system in the 4 weeks before their death. And then 34% of people 15 years or older had contact with a health care provider in the week before their death. So these people are having contact with our healthcare systems. We're just not identifying them. So that's where that universal screening comes in. Next slide. Okay, I'm not going to spend a ton of time on this, but basically the purpose of this slide is to show you that Store It Safe is growing and continuing to do more work. We're spreading throughout the state, and we're really excited that you guys are participating in this wave. This particular wave, I think, is unique and special, and I'm really excited as we start moving through this. Next slide. Okay. So one of the major questions that I think Kristen gets as well as myself is, well, we're already screening for depression. Do I really need to screen for suicide? Yes. The answer is yes. So screening for depression is going to miss 36% of pediatric patients who are suicidal. You don't have to be depressed to be suicidal. So yes, absolutely screening for depression is important. I use the PHQ-8. you know, hopefully you're all using some sort of validated screening tool. If you're not, like, we can help you with that. But you really need to screen for both. So the ASQ is a screening tool that I use. It's the one that we're going to talk about when we get to that section. But I just really want to reinforce that you've got to do both. Next slide. Okay, so I mentioned at the very, when I was sharing that slide about, the preteens, this is what the recommendations are currently. So universal screening for kids 12 and up. Now, I will say, like, sometimes you will have maybe someone who is like developmentally delayed or something like that, and they can't answer the questions. Like, obviously there's exceptions, but this is just kind of the general guidelines. So universal screening for suicide and depression, 12 and up. And then when clinically indicated in that 8 to 11 age group, and then under age 8, they don't really recommend screening, but definitely assessing for suicidal thoughts and behaviors if there's warning signs present. Next slide. So this is the kind of inverted pyramid that walks you through kind of the suicide screening. So the brief screen is about 20 seconds long, the ASQ. It is 5 questions. It is so fast. I promise you it is not going to add any length to your visits. And then if it's positive, then someone in your office would do the brief suicide safety assessment. And then, if they're like in acute crisis, then obviously you would take the appropriate next steps. If they're not, maybe you do a safety plan, which we'll talk about in a second, see them back in a week or whatever it is that you need to do. Next slide. Okay, so this is the safety plan that we use. It's pretty easy. And so we work with the child to complete this. And obviously the family is a part of this discussion too, because they're going to need to help support them. But, a child going into crisis looks different. Every child's different. The triggers are different. What calms them is different. So really doing having the child tell you, okay, what are some signs that I'm really like struggling? And what is something you can do? What is helpful? What is not? Sometimes people are super well-meaning, but what they're doing is actually not helpful. So this is really helpful. The other thing that I always do, and this is here in step 4, like with my own children, is like, who are people you can talk to outside of our home? Is there a coach? Is it a neighbor? Is it a parent of one of your other friends. Like, identify some key people that you feel comfortable talking to outside of our family. Okay, next slide. Okay, so this is an example of a flow chart of like how you might implement this and what kind of standardized process you might put into place. One thing you'll notice is across the top is that every adolescent who's coming in for a preventative visit, so that's a well child visit or a sports physical, gets all three pieces of this. Okay, so what does that mean? They get screened for depression, they get screened for suicide, and then you discuss restriction of access to lethal means. And the reason why every single kid gets this is because what is going to put a child into crisis, we don't know what it's going to be. It may be something that is like seemingly very small. It may be in a student who has never had a history of any mental health problems at all. And it may come on so quickly that if we haven't had those discussions in advance, it may be too late. So, honor roll student, quarterback of the football team, student council president, like everything's great, never had any issues in the past. This discussion needs to happen with them. Regardless of whatever preconceived notions we have, this conversation still needs to happen because we just don't know what's going to happen when and to whom. So then there's just some guides here. So, not everyone who screens positive for depression needs, to go to the ER, right? Like, we can manage a lot of this in the office. So there's just some different resources here. The PHQ severity guide, we included here a sample safety plan that I showed you an example of, the ASQ toolkit. So the ASQ toolkit is really nice. It walks you through like, how do you implement this into your practice? So you can use that QR code to find all those resources. And then, some suggestions around like, you might want to talk about starting medication. You might want to do a crisis plan. You might want to do a referral. Same thing with the ASQ. A yes does not, a yes on any of the first four questions does not necessarily mean that you need to send them immediately to the emergency room. Those could be non-acute positives. Now, if there's yes to question 5, which is like, I'm in imminent danger of killing myself, you need to get like a one-on-one sitter and get them to the emergency department. That is an imminent crisis. But questions 1 through 4, but no to question 5, we would call that a non-acute positive. And then, but definitely like there needs to be evaluation. So you would do that further assessment. You would do your safety plan. You'd get them linked with mental health services. Okay, so screening and billing, you can bill for doing both of these things. So you can do the brief emotional behavioral assessment screening tool for both, and then do a 59 modifier on the second screening tool. So if you do the PHQ and the ASQ, you do your 59 modifier on the second one, then you get reimbursed for both. So I put a couple things down there because of various insurance and payers and that kind of thing that might be helpful. But I do want to encourage you that if you are doing both screens, that you bill for both screens. Next slide. Okay, so I included these links here, the blueprint that I mentioned and referred to, and then the ASQ toolkit. So these are the internet links that are the same as the QR links that we included in the sample office flow. Next slide. Okay, Kristen, do you want me to go through this part?
Yeah, sure, you can.
Okay.
And
Okay.
I'm happy to jump in if you want.
Okay. No, I'm happy to. So one of the things that we learned when we first started this project around Store It Safe was that a lot of times providers are uncomfortable about talking about guns for good reasons. Some of us are more comfortable or less comfortable with the topic in general. Some of us are worried about how our families would respond. But really framing this as a safety issue. So you talk about wearing a seatbelt, you talk about drugs and alcohol, like this is just part of the safety speech. So we came up with some guides, and we did this with our partners that include like Buckeye Firearms, some concealed carry instructors, some people from the industry to help us with wording, help us with perception when we're talking to families to try and make it as non-judgmental as we can. So we've come up. This is the resource for providers where it talks about screening, it talks about intervening, treatment. It also has that workflow that I talked about. And all of these resources are available on our website. They are free. And we encourage you to use them, download them, print them, use whatever it is that you want. Okay, next
And
slide.
we will be sending printed versions as well of these to you,
Perfect.
shipping them to you.
Great. Next slide. Okay, I really, really like, have my favorites. This one and the youth rack card are my favorites because I feel like these are really helpful for families. So initially when we created the family resource, it was this like packet, like chock full of information, which is great for families who really want to dive deep. But if you're in the middle of a crisis, like it's not helpful. So we created this rack card separate that are like, what is it that we want every family to know? And the first thing is you don't wait to be in the crisis to plan for a crisis. You need to do that when everyone's calm and you plan in advance. Obviously, providing a safe environment. What are some things that if, I'm a mom and I'm at home with my teenager and they've never had a crisis, but now they're in crisis, what are some de-escalation tools that I can use? So it just talks through the 5, 4, 3, 2, 1 strategy, and then provides family with some resources. So in an immediate crisis, this is what you can do. So I think it really helps empowers families to feel like they have some control in the situation that feels really, really out of control. And then, again, on the flip side of it, talking about restricting access, talking about that safety plan, and understanding that, yeah, you might be in a crisis, but let's be as prepared as we can in advance so that we, handle it as best as possible when we are in a crisis. Next slide. Okay, and this is one of our newer resources. We are partnered with Lifeside Ohio, and we created it in partnership with Buckeye Firearms. This is a resource specific for firearm owners, and it just talks about different ways that you can secure firearms. And again, we're thinking also about other lethal means. So that's the nice thing about the boxes is, if they have edible marijuana, they can put it in there. If they have medication, they can put it in the lockbox. So that is why, for the purposes of this quality improvement, we talk a lot about lockboxes. Next slide. Okay, and then this is my other favorite. So this is one specific for teens. And what I like about this is I feel like using this rack card helps me open that conversation about suicide, because I kind of talk about to the teen, if you have a friend in this situation, that kind of just starts getting the discussion going without the patient feeling like I'm, you know, talking directly about them. But it talks about signs of suicide. It talks about things you can do. When I used to work in the ER, I can't tell you how many suicidal youth would come in and they had disclosed to a friend that they wanted to kill themselves, and then that friend took the appropriate action of telling a trusted adult. But if you're 15 and you're having your own issues, and then your friend tells you they want to kill themselves, but don't tell anyone, how do you navigate that? That's really, really hard. Do you betray your friend's trust and tell a trusted adult? Yes, but like we need to impact, like let them know like that's okay to do that in that instant because you're going to save a life. So this is one specific for teens where it really kind of talks them through things that they can do for themselves if they're starting to feel overwhelmed, if they're in crisis, what they can do, signs of suicide. So if they notice like their friend is acting a certain way, maybe those are red flags and they need to tell a trusted adult. So I use this one a lot in my clinic. Next slide. And then what we did with that like big packet that I was telling you about is we turned it into this digital resource because sometimes families do want to know a lot more detail. So this is a digital resource that's super easy to navigate. You can see those tabs over there on the right, and you can provide this link to families and then they can review it at their leisure. Next slide.
And it is that QR code that's on all those other resources that you will be given to the families. So
Mhm.
all they have to do really is scan that QR code and it'll take them to this resource if they're interested in looking a little more in depth.
Yep.
All right, and I think this is where I take over a bit, but Dr. Denny, please feel free to jump in. This is where we talk just through just a little bit more of an overview of the project. And as you know, the aim, of course, is to increase depression screening, suicidality screening, and appropriate intervention, referral, and then safe in-home storage of lethal means. We do have a key driver diagram for the project that I will email to all of you so you have it. It's like that sort of guiding roadmap for us. There's a lot of detail in this. I'm not going to go through it all, but this is just where we kind of keep everything summarized on the things that we're going to be working on and doing. As Dr. Denny has already mentioned, this is probably one of the most important concepts of the project. It really does take a team. And she's already mentioned that, but one of the reasons we like to do these learning sessions kind of in sort of 2-week increments is just to not overload everyone with things, but to give you some information, get you talking with your clinic and team about the project and thinking about kind of how you are going to take the steps to implement it, who's going to have what responsibilities, and we're going to work on a really nice workflow so that for each of your clinics, you'll have that to refer to. And again, we always say we give recommendations, we give suggestions, but we know that every practice and every clinic is different, so it's not going to look exactly the same for everybody. And again, I know many of you, we've already talked through this slide in our initial meetings, but these are the things the project is going to focus on. And we do have that sort of last part in the data entry when a parent or a caregiver, if they're at the appointment, actually enters some answers to some questions. So we'll talk more about that at the next learning session as well. To give you that high level timeline, and again, I've shared this with most of you already, the project's going to be running from September sort of through the end of May, June time period. We're really gearing up this month. And then in October, we'll actually start the data entry process. You'll submit a workflow that you'll be working on that we're going to go through today, but then, and I'll send you a template for completing that. And then we start coaching calls and PDSAs and our action period calls. And that data collection and then having our touch bases for more education and checking in will run through May, which will be our last month of data entry, and you'll finish up with an exit interview and a final confidence survey. Again, as we mentioned, today's our first learning session where we're focusing on screening and overview. And then our next session, which will be in 2 weeks, will be focused on data and then more on the workflow. And I will be sending you iPads after today's session, so you will have those in hand. So once you get those, start taking a look, playing around, and bring them to the next session because we'll be talking a lot about how to do data entry. And then your final session is those lethal means restriction conversations that Dr. Denny has mentioned. We're going to have a whole session on just how to do that. And actually, we'll have a virtual reality platform that you'll get to actually practice those conversations with avatars, which is really a fun session. You all probably already know, but the action period calls that we'll have, that's where all the practices will join together. We'll typically have a related topic, and those will be similar to this, 45 minutes over the lunch hour. I'll be scheduling those calls in December, February, and April, and you'll be getting calendar holds for those. And then those, your clinic, everyone is always welcome to attend. We do record them, but we do ask that you have like your core QI team members attend those. Coaching calls are a little different. That's where you will have sort of an individual call with me, with Dr. Denny, perhaps, if you're struggling with something with, the lethal means conversations or something like that. It's just really to address individual needs of clinics. We'll have at least three of those, more if they're needed. And again, anytime you have questions or challenges, you're welcome to reach out and we can have calls or even just help with emails through email if that's helpful. And those will be held at convenient times for you. And then those likely will also be during the month shown, but again, they can be anytime. Those can be 30 to 60 minutes, just really depending on what we need. And if we need to do an in-person visit, we're also always welcome you're always welcome to have us come for in-person site visits as well. I'll talk a lot more about PDSA cycle worksheets and give you those. Many of you may have already done them, but you'll have 2 of those basically due during the project, and those will happen in the months of November and February. And then just to remind you, the benefits to the project are any participating provider does get the 25 points of MOC credit. Each participating clinic does get $1,000 stipend, and which we have talked about that too in our intro calls. You will get safety lock boxes, like I mentioned to you, that are shipped directly to the practices, and then the iPads that you'll use for data entry. So just to get you thinking a little bit about those clinic workflows, you're going to probably have flows, some of which you may already be doing with screening. If you're doing depression screening, you probably already have a nice flow set up for that. But now you're going to be adding in suicidality screening, so that might change things up a bit. There's going to be a flow for how you'll do the lethal means restriction discussion and that kind of process, and then giving resources and data entry. So then some things to start thinking about for screening. So remember that you are going to, most of you likely will be adding that separate suicidality screening. So be thinking about how that's going to impact your current process. We do recommend that youth complete those screenings privately. They're not asked the questions, but they actually confidentially take those screenings and complete them. Be thinking about who's going to review those screenings. Who does the scoring? How does, if it's not the provider doing that, which many times it's not, how does the provider actually know that screening result before they go in to see their family? And then how does a provider communicate about the screenings to the patient and the caregiver? And then documenting that and data entry is something to just, again, keep in mind. So again, I'm going to show you what is just a suggested or a recommended flow. This may not work for your practice, and you're certainly welcome to tweak this, but we've seen this used pretty successfully. So you often will have the front office staff, as Dr. Denny mentioned, that would give the screenings actually to the patients to complete while they're in the waiting room. And then what might happen next is some type of clinical staff, it might be an MA, a nurse, would collect those screenings, score them, and sort of have that done prior to the provider seeing the patient. They would document the screening results in the chart and on the iPad, which again, when you see the iPads and we talk through that, that'll make a lot more sense to you. And then the provider would, prior to seeing the patient, review the screening results, or while they're in the room with the patient, review those, maybe communicate the screening results or talk about that. If needed, develop a treatment plan, a referral, and then complete documentation, which would be in the chart potentially, and then there's some data entry on the iPad. The lethal means restriction piece of the project. So we do recommend that the provider is the person who has this discussion with the parent and caregiver, regardless of the screening results. So remember, that's very important. This is not in any way connected to the results of the screening. It's with every adolescent patient age 12 to 21 that comes for a preventative visit. The youth may or may not be present when you have this discussion with the parent or caregiver, so they may be in the room, they often are, or that may be at a time when the caregiver and the youth are not together at the appointment. You should also always offer the lockbox. So again, doesn't have to be offered only when someone indicates they have a firearm in the home. It's offered all the time across the board, as are the Store It Safe resources. And then there's documentation related to that. So again, this is just a suggested flow. And we always stress this, always done regardless of the screening results. So this is a population sort of based discussion. The provider would have the lethal restriction discussion with the parent or caregiver, which again, we're going to have a lot more discussion about in that third learning session. They would give the crisis rack card and the firearm owner resource to the parent caregiver. Again, even if the parent caregiver doesn't indicate they own a firearm, they may know someone who does, and it's a great resource to have. They would give the youth rack card to the patient and offer the safety lockbox to the family, and then again, document this in the chart, and then the data entry on the iPad. So the next time that we meet, we're going to kind of put all of these things together with data entry on the iPad. I promise you, It's very quick and easy. It's less than a 2-minute process. We have worked for years to try to make data collection and data entry be as efficient as possible. We don't want you spending your time with data. We want you spending your time taking care of kids and families. So, but in quality improvement, data is very important, and it helps us do a better job clinically when we're looking at that data. So, this is the method we've come up with, and it's worked very well in previous waves, and we're going to go through it in detail so that it's not confusing. So be on the lookout for your iPads, and then, like I said, play around with them, and we'll go through it all the next time. So a couple of things for me to remind you. Many of you have already done this, but if you have not sent me the contact name and the mailing address for your practice so that I can get your iPads out to you. That will also be the mailing address I use for your resources and your lock boxes. So get me that as soon as you can. Start pulling your team together. So think about, now that you know a little bit more about kind of what your practice is going to be doing with the project, that you're talking about the project with your team and kind of figuring out who's going to be doing what. I'll be sending out a follow-up email to you with a lot of information, the slides, links to the ASQ toolkit, the digital link to the resources, those kind of things. So just be on the lookout for that, and it'll have a few to-dos to remind you of. And then start thinking about the workflow. And again, you'll get a template from me on how to kind of draft this all out. It doesn't have to be anything crazy. It's really sort of tweaking the flow that I just showed you to make it work for your practice. There is a brief pre-work survey. There'll be a link to that to complete. And then I'll be sending out calendar invites as well for the next 2 sessions, and ask questions. We know that over the next, few sessions, we're bombarding you with a lot of information in a short period of time. So we're here to answer questions. We're here to help. I'll make sure in that email you all have my cell phone to text. I get email on my cell phone. I'm able to access Dr. Denny for questions as well. So please, please, please don't hesitate to ask questions. Couple other reminders. We have our annual meeting coming up at the end of October. Liz Dawson just showed me this amazing indoor campfire that we're going to have. I can't believe it. It's the coolest thing ever. So we would love to see you there. You have the QR code for a registration link, and it's also on our website. It is free to Ohio AAP members, so we would love to see you all there. I also want to mention one of the fundraising event at annual meeting, and then a 90 pay for 90 year campaign that we're doing is also around Store It Safe. So if you would like to donate, you'll have these slides, or spread the word. We're trying to raise $90,000 to continue spreading the work and resources of Store It Safe across Ohio. And then again, my email address and my cell phone that you can text with questions. And then I think we actually have 7 minutes, which I can't believe how quickly we went through that. We must have talked rapidly, but we do have a few minutes for questions. So please feel free to unmute yourself. If you have any questions right now, we'd be happy to answer those.
I just wanted to make a comment, just going back to what Kristen said at the very beginning with that team slide that she shared, is that a lot of time, or not a lot of times, occasionally, a provider is like really passionate about this, and they want to do this quality improvement program, but they don't have a team. And it is really difficult to be successful in this work unless you are doing this as a team. So hopefully those of you who are logged on, you're logged on and you have your like Reg and your nurse and your social worker there with you listening. And if not, then, maybe you send them the recording of this. But it's really helpful to get everyone on the same page and to like set up some sort of cadence of regular meetings on how you're going to do this work. Because it definitely takes everyone. It's not a heavy lift if everyone's doing it, because it flows so easily and so smoothly. I've been doing it for years in my clinic, and I don't even think of it. Like, it's just so easy. But it does take everyone being on board with what the plan is, what the process is, to make it really function well.
All right, any other comments or questions? All right, well, thank you all so much for joining us. Again, don't hesitate to reach out, and we will look forward to seeing you again for the next session, and be on the lookout for those iPads and my follow-up email.